Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsburg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
81-year-old man with a prior smoking history, just 20 pack years, but with significant memory difficulties, a new diagnosis of a right lower lobe adenocarcinoma with mucinous features, and has been tested for molecular factors, no driver mutation among EGFR, ALK, or ROS, and 50% PDL1. And questionable mediastinal adenopathy, we'll have a chance to look at that. He's pleasant, he responds appropriately, but he doesn't remember his lung cancer diagnosis and really can't participate in detailed discussion. His performance status overall is 2. The patient himself, to the extent that he can speak to this, and the family are reluctant about chemotherapy, even if that's recommended. And his past medical history includes hypertension, the memory issues above, hypothyroidism. Smoking history, quits alcohol 10 years ago. And questions include essentially what further workup would be appropriate here and leading treatment options. And if we can get more detailed, Dr. Ginsburg, if you can walk us through the imaging.
So we're looking at our axial images from a PET CT, where we see that the lesion measures 3.7 cm in maximal dimension in the right lower lobe and is avid with a 6.8 SUV. There are some smaller lymph nodes in the mediastinum, in the right paratracheal, and also in the contralateral left hilar region, which are slightly avid at 3.5 and 3.9, but they are avid, and it is a contralateral lymph node that's concerning in the left hilar region, given that this is a right lower lobe mass.
Dr. Ginsburg, can I ask you a question? I know it's hard because we don't have the full scan there, but in looking at that scan on the left, it looks like he's got some mild interstitial lung changes on there. I don't know if it's just not enough to look at, but
it might be. Unfortunately, these images are from the PET CT, and the CT that comes with a PET scan is not good it's done with the patient breathing. So it's not a good expanded lung CT. So we would be extrapolating a little bit beyond. It could just be that it's just not a good inspiratory effort. So I would say we need a dedicated CT, which would look at that better.
So we have the PET CT results. We have a biopsy that shows adenocarcinoma with mucinous features. Again, TTF1 and napsin focally positive, and other immunohistochemistry shown. Molecular testing we reviewed, and he's unable to be fully compliant and participate in pulmonary function tests. So that's a limitation. So let me just ask broadly, what do people think? Where is your level of enthusiasm for moving ahead with this? I would actually just raise the question that I would have concern that this may not be that aggressive, and that it may arguably not be that as clinically relevant as we reflexively think about. And again, this is one that we don't have any kind of historical, we don't have changes over time to speak to. We do have an SUV that is not especially high uptake. So I'll start with you, Dr. Force, if you can speak to whether you think this is someone who you would advise more of a workup, mediastinal staging, and or whether you would be more inclined to de-escalate here.
So, I mean, it would definitely be, so let me start by saying, I think it's very unlikely that I would recommend surgery to this patient based on the cognitive deficits he has. He couldn't even do breathing function tests. The SUV may be a little bit of a hook, because we know that the mucinous adenocarcinomas don't take up, and Dr. Ginsburg can probably talk more intelligently than I can, but they don't take up the FDG as well as non-mucinous adenocarcinomas. So the low S, sometimes they don't show up at all. So I do think it would be, if we could, it'd be nice to do kind of a minimally invasive staging. I think he should, get a bronchoscopy with biopsy of the lymph nodes and MRI of the brain, because that's going to help determine treatment. So if he's got very advanced disease, and I 100% agree, I don't think he probably wouldn't get any treatment, because he's not going to tolerate it. If he's got localized disease, the question is, can he even sit still long enough to get stereotactic radiation? That would be a question for Dr. Robinson, because this may be one of the patients he was talking about where they succumb to their other medical problems versus the surgery. I do think local, stereotactic radiation would be good if it's localized to that area, if the patient could sit there and not move around for it. But that may be a big if.
Well, and I think I'll let Dr. Robinson speak to the role of local therapy. I would say, and Dr. Ramalingam, you can comment as well. I think that the leading option would be probably pembrolizumab immunotherapy, which is not chemotherapy and can be very well tolerated. But I think that needs to be weighed against the alternative of not treating and seeing how things go just with the natural history. But Dr. Robinson, can you speak to your level of interest, enthusiasm, and commitment to pushing forward with this gentleman versus deferring to kind of systemic therapy or nothing?
Yeah, I have a number of thoughts. I think that first off, I echo everything that everyone else said. Particularly if possible, if this patient could tolerate it, doing at least some sort of minimally invasive staging. While it might be tempting to look at that kind of confluent lymph node, low grade SUV, and just chalk that up to inflammatory or granulomatous disease, particularly with some of that calcifications in the left hilum. Obviously, we see patients who have cancer in lymph nodes that coexist with that. But if, this guy really is as sick as it sounds he is, and we're going to have to make our decisions based on best clinical judgment, SBRT is a possibility. We certainly have the ability to handle folks who maybe don't handle directions very well or struggle with that. We've had family members come to the console and speak to them through the speaker while we're doing it. We can pause and abort. We can actually pause in the middle of treatment. So, you can deliver a single arc and then see how they're doing, and then deliver another one. The treatments now, particularly those people who maybe grew up along with the rest of us doing SBRT and watching it from its infancy, typically those treatments when we first started doing them took on an order of an hour to an hour and a half. The last patient I treated this week, it was 5 minutes. So there are ways to now deliver this very, very quickly. Whether it should be done, again, I think is the question. One could consider that if he's really struggling, since we don't have serial imaging, this could be a patient where you could potentially do an interval scan, get a sense of the rapidity of growth of something like this and whether there's additional changes occurring in the lymph nodes or otherwise. While that violates the mantra that we talked about in terms of not delaying therapy, in this case, it's a decision-making point.
I would actually say that in this case, time and serial imaging is a valuable diagnostic tool, or at least an important factor to understand. As a general principle, we are struggling to not undertreat or overtreat people, and there is a real potential danger in overtreating this person. Ram, what are your thoughts here? Would you, based on what you have now, would you favor potentially moving forward with systemic therapy, presumably pembro monotherapy if that's the case, serial imaging and kind of, I wouldn't exactly say foot dragging, but gathering more information, or go with local therapy if that's feasible as soon as possible?
So my approach would be to hold the systemic therapy until I have a little more compelling reason to think that this is a more widespread problem. And, I would really look up to our radiation oncology team, Dr. Robinson, to see if he can even treat the primary and then watch the patient closely to see if there's evidence of progression. And if there is progression and the overall direction is to do something, then I would definitely consider pembrolizumab as monotherapy. At this point, as we are contemplating the pros and cons of various approaches, I wouldn't put that on the table. Or at least I would be reluctant to put that on the table.
Be reluctant to put pembro as
right, a systemic therapy option on the table. In this case, if we went in that direction, pembro obviously would be the
choice. Yeah.
Most, obviously.
So if I would summarize at this point by saying that for this particular gentleman, given the limitations in his ability to participate in the process and cooperate well, but also given the ambiguity about whether it's really clinically necessary, there's not a lot of enthusiasm about any aggressive treatment with potential adverse effects. Surgery being one that we have really little enthusiasm about, radiation being an option to consider, pembrolizumab also being an option that could be done. But I would say that we have good interest, I think the greatest consensus around getting more information by serial imaging and just looking at the changes or lack of changes over time, with an understanding that if there is relatively little change over several months and the possibility of following up and managing expectantly, that's really arguably the most attractive approach.
And I think just one last thing surgically, and it would, it's a fairly large lesion, but in some of these patients, we elect to not do the oncologically best surgery. And, we could do a wedge resection and a mediastinal lymph node staging through a minimally invasive surgery in about an hour. So, that's very different than, a much bigger lobectomy, 2 to 3 hours and a longer hospital stay. The wedge resection and the lymph node sampling, patients stay, overnight in the hospital and go home the next day. So you could consider a lower risk surgical therapies that may not be the optimal cancer operation, but maybe the best one for this guy if we were going to consider surgery.